Rachel and Renee. How are you guys doing today?
So happy to be here.
Yes, great. Sarah, nice to actually spend some time with you.
Yeah, I am so excited to have you guys on today. And I think it's going to be a great, awesome episode, kind of showing that relationship between nursing and security. So I'm excited to jump right in. Rachel, why don't you go ahead and tell us like a little bit about yourself and what's your role in security?
Absolutely. So I'm Rachel Meints. I am the Director of Security Investigations for UC Health. At our organization, we've really divided security into multiple components. So we have a Director of Technology, we have a Director of Operations who oversees the day-to-day operations of our security vendor, and then we have Security Investigations. So a real focus on behavioral threat assessment, investigation, and response to the crimes that are committed against our staff and on our property, and liaison with the local police departments to help further those efforts.
That's awesome that you guys have it kind of structured like that. So I can't wait to hear more about that. And Renee, please tell us a little bit about yourself.
Sure. So my name's Renee. I am first and foremost an ER nurse. I moved into a dedicated workplace violence prevention clinical quality specialist role. It is a very different type of role. It's under a quality umbrella, but it's specific to workplace violence. So it looks at, we do a lot of case reviews, and we look at operationalizing and implementing policies that are set, having a really strong partnership with our behavioral health professionals, our security partners, our providers, our nurses, techs. It's kind of like this intermediary person to bring everybody together and focus on how we can create a safer environment for patients.
This sounds like the perfect role for a nurse, for an
Great.
emergency room nurse. um, so, Rachel, I'm curious, can you kind of, how do security investigators kind of approach threats like aggression and theft in hospitals and the clinics?
Absolutely. So we really try to focus on data driven solutions. And I think for a long time, that's been the trend in nursing interventions. And I think we need to apply that to security as well. Where are areas where we're seeing our most disruptive patients, our most volatile situations? Where are the areas where we're seeing kind of the petty crimes? And what are some of the solutions and the root causes for those? So we really take a lot of this analytical approach that we see in a lot of our quality nursing roles, but we're applying that to the security side as well. And we're providing a resource for staff to ask questions because when you're talking about the legal system after you've been assaulted, that is not the time to ask, hey, what does it look like when I need to file a police report? What can I expect from the response or my required participation? So, a lot of that knowledge building as well, kind of understanding what this process looks like. What are my rights as a victim of a crime? What can be expected of me? What kind of support can I expect from our system? And really driving those policies.
No, that is amazing. So I don't even have a question for that, but I'm going to ask a question for that because I love to hear that. So, how are you guys getting that kind of information out to your staff? Like, how are you educating them?
Yeah, I was hired to create the program 4 years ago in March of 2021. And we were very intentional for those first 2 years of building the knowledge base, identifying what is it that staff keep asking us over and over and over again? What are those trends across the system? And it's a fairly large system. We're talking about 50,000 employees, providers, vendors. What are some of those most common questions? And then let's form dedicated trainings based on those. So we have several 50-minute blocks that are available. So we talk about this is what it looks like to report to police. That is about a 30-minute training class. We talk about this is basic security awareness. So let's keep you from getting hit in the first place to the best ability that we can. Let's look at what our response, our multidisciplinary response to an agitated patient looks like and see how security might be able to enhance that response. And then let's take a look at what is behavioral threat assessment. And for our organization, that was a brand new term. So we spent a lot of time talking about let's identify behaviors of concern in our patients, in our visitors, in sometimes staff members, if that's the case. And what are some of those things that staff should be reporting to us? We spent 2 years doing that before we ever got to a point where we could roll out system wide groups to take a look at those events.
Wow, that's amazing. So you guys really laid like the ground, like the foundation, right? You really had to lay that groundwork and that foundation for that. So that's amazing. So you just had like little 30-minute blocks that people could just like sign up and attend, or is that what you guys
Absolutely.
did? Yeah, okay.
Absolutely. So we presented at our safety huddles as just kind of a high level introduction to the idea. We presented at unit specific meetings, at charge nurse meetings, and then long term, we developed permanent online trainings for those different topics as well that are assigned to staff every year to complete.
Okay. All right. That's fantastic. What are some of the challenges that you faced when you were rolling that out?
I think one of the biggest things was everybody kind of has this idea of what a threat is. And there are a lot of things in the world that make us feel unsafe, but aren't necessarily the things that are causing us to be unsafe. And it can feel really counterintuitive when you hear somebody threaten to kill you. That person maybe isn't the person that we should be focusing on. We should be focusing on the patient who is giving us a lot of really indirect communications that indicates that they're planning to harm somebody. So, really redirecting those viewpoints about what we feel versus what the data tells us. And we really took this data driven approach to make sure that our staff were armed with knowledge, first and foremost, that they understood what the statistics show us and what the studies show us as well. And it wasn't just, hey, this is a great new idea. It's this is 20 years, 30 years of research that is showing us these behaviors are consistent in 80% of cases.
Gotcha. So it's being intentional, and then also kind of that extra education component piece. And I know at some point I'll talk about how fear is really a driver, I think, for both patients and staff. And some of the self-defense training I do, the instructor, his acronym for fear is false evidence appearing real. And so it's really like balancing that, okay, what's the real evidence, and is there a legitimate fear here, or where is that fight or flight in my, autonomic nervous system response to what's going on? So do you Renee, I'm going to ask you, do you think some of that training has kind of really helped clinical staff in how they respond to aggression and violence?
Yes, so much. So a lot of what I noticed when I move into this role is that we have this fantastic structure. We have these resources, we have this education, but translating it to the bedside and really getting it into the working knowledge and kind of overcoming some of our natural, the things that we're trained when you go to nursing school, right? You jump in, you walk into a room, you get the blood cultures, you walk into a room, you put some EKG leads on. And the evidence really shows you need to take a minute. Like we actually need to walk in and evaluate our environment, but being able to override that drive to go super fast and be super efficient and put the patient 100% ahead of your own safety is a work in progress. And without this foundation, we wouldn't be able to translate any of what we hope to teach when we talk about environmental awareness or de-escalation training. You have to be able to work that into your mental load of, but I have a time constraint. I have a metric I have to meet, right? I have 5 other patients, one passing has to be here. And if you can override that with data and with evidence and with repeated messaging from interdisciplinary teams, including security, including behavioral health, including your leadership, you see so much more success in culture change and integrating these things into practice.
Yeah, when Rachel was talking that security was kind of taking some things from clinical, I was hoping we would get to where clinical needs to start taking some things from security. Because, and if you think putting a clinical spin on that, patients' social detriments and what they have going on in their life, the environment that they're growing up in, the environment that they live in, like all of these have impacts on their lives, right? And so I agree, like in nursing and in medicine, we get so focused on like the disease or the disorder and how do we, focus on that, but we're not trained and haven't gotten to a point where we really start to take into consideration everything that's going on in the person's life. I think there's a lot more evidence that's starting to support that, like how much like just people's environments really affect their health. I mean, we could get into domestic violence statistics and talk about all the diseases and disorders that, domestic violence victims have an increased risk of. So when it comes to clinical, it's really understanding and taking that into account. So I think that's fabulous that you guys are really starting to kind of integrate that into your clinical practice there. So you, Renee, you guys implemented aggression screening tools. Can you kind of tell me a little bit about those, and then what led to the decision? Because there's a few of them. What led to the decision for you guys to use the screening tool that you're using?
Sure. So I will fully admit that I was a bedside nurse at the time that this was rolled out. So the violence prediction tool that we used, many were evaluated. We looked at the literature, we looked at what was evidence-based, what was cost-effective, what was easy to educate to, and what was reasonable to use in a quick environment. There were some tools, a lot of tools that have been validated in the forensic setting or in an outpatient or inpatient psychiatric setting. And those are really detailed. And we needed something that we could use and train to that didn't require an in-depth assessment, for lack of a better term, into a person's background or underlying psychological issues. And so when we decided on the tool that would be used, it was rolled out initially for inpatient and the emergency department. I believe about a year and a half in, our UC Health has a research nurse scientist who's fantastic. She had a team of people. Her name's Sarah Spencer, and they worked on validating the tool in an inpatient setting, and that has further embedded this tool into our practice and the way that we've operationalized it at the bedside. How can we identify behaviors and become aware of these behaviors that we wouldn't normally be looking for? And then what do we do when we start to see them, right? Because we're predicting the escalation of violence in a 24-hour period. So if we're screening this tool regularly and documenting when we're seeing changes, then we're able to implement those early interventions and communicate among the team to really be able to keep ourselves safe, but also our patients safe. The same as what we do when we're looking at a risk factor for decompensation on an inpatient unit or in an ICU, or a risk for any kind of, PPE required illness, MRSA, right now measles, any of those things. This is the same tool.
Yeah, so it's more looking at like, what are the symptoms right now, right? What are the behaviors? What are the symptoms right now? Let's kind of quantify it, right? Mm-hmm. So we know how to who to get involved, but we're not necessarily looking at root cause analysis necessarily just yet, right? That's where Rachel comes in with the threat assessment teams. And so is that something like if you're getting a higher number than your guys' policy, like you reach out to security?
Yeah, so right now, it's not necessarily if you have a higher number, but it's sort of what you're seeing. So a couple of examples, you can score, a high risk for violent behaviors. And those violent behaviors are really in the healthcare setting. We're not looking at if they've been discharged, what is their risk for violence in the community. We've kept the scope very limited to the healthcare setting. But one of the things that is measured is verbally threatening behaviors. And so we have had patients who've said, I'm going to come back and shoot you, or I'm going to, making motions, but pretending to shoot. That is something that would trigger that's a poor use of the word trigger, but that is something that would then prompt looping in our security team and our behavioral health threat assessment team to kind of see, hey, is this someone who is, squawking,
credible,
but not walking, right? Or is this a credible threat? What do we need to worry about here? And so that tool allows us to capture it. When we have nurses who document very well, who, will say verbally threatening, and here is what they threatened, or here is what they said. That gives us these direct quotes that are very objective to be able to then go in and see, hey, what do we need to do here? What are our concerns? And security also always has their training and ears listening and eyes watching to be able to say, this seems a little out of place. We need to escalate this. So it's a good collaboration.
It sounds like it. And good catch and good reframe there on the
yeah.
from triggering to prompting. That was
Hmm.
perfect. And so, Rachel, when you guys are prompted and kind of called with the behavioral threat assessment, how does that look? How do you guys take over from there?
Yeah, so I think there's a couple of components. So there are the assessments that are triggered from our violence risk screening tool. And I was part of that rollout initially. So our security team was able, and we picked a simple tool so that our security team would have knowledge of the different questions that were being asked. And they were provided a toolkit of different things that we can do to prevent that person from escalating further. Can be as simple as just sending a friendly face in to connect with that patient and really try to de escalate the person. When we get to the levels of behavioral threat assessment, we're really talking about behaviors of concern, specific threats, direct threats, even implied threats. And that looks a little bit different. So when we're talking about behavioral threat assessment, it is really a whole other level of review and assessment. So there's the initial screening, and what we're trying to do is figure out the credibility of the report itself, but then also the credibility of the threat. Does this person have the means and the capability to carry out that threat? We start with a background check always, because in God we trust, but everybody else is getting a background check as part of this process if they have made a threat. And then we're going to look at what other information is available to us. Is this part of this patient's baseline? Is this part of this person's baseline? Do we see similar behaviors in the past? Is this just a behavioral issue that we now need to focus on addressing? Or is this new and escalating behavior? And if this is new and escalating behavior, what is the grievance that we've identified here that we need to redirect this person for? And if we think that this is a credible threat or there is some kind of credible report that we need to address, at that point, we trigger our threat management teams and they will conduct a comprehensive review using a different tool. So, a much more detailed tool that asks a lot of questions, talks a lot about social history, criminal history, any sort of underlying psychiatric concerns that we might have, social concerns that we might have, criminal history, all of the information that we can collect about this person to really inform responses. Because over responding to a threat can be just as dangerous as under responding. So we want to have a full picture of that person's behaviors. And that then triggers, this is our management plan. This is what we're going to do to redirect this person. And it might be, hey, this person just needs a security escort or somebody to check in with them. They might need a secondary search if they're going to present to our facility because they've threatened use of a weapon or told us, hey, I can get a knife in here or a gun in here, no problem. You guys aren't very good at what you do. Well, thank you for telling us that. You're definitely getting a secondary search at this point. So we're creating kind of an all of the above approach in response to those threats. And then we're going to continue to monitor that person. So it's not a one and done tool. It is, as long as we see the behaviors and if we continue to see escalation, we'll continue to monitor and adjust.
So, how many, so kind of off camera before we got on, you said you actually have 4 teams. So, I'm curious kind of the structure of that and what professional disciplines that you have on those teams.
Absolutely. I mean, we've really replicated the DHS and FBI best practices that they've outlined here. Multidisciplinary teams are always key no matter what tool you pick as an organization. So that a team includes our house supervisors, it includes nursing leaders, it includes operational leadership from the different facilities. We take a regional approach for that so that we don't burn out any one person on the team. It includes legal, as always. You definitely need to make the lawyer your friend as part of this process so that you're getting good quality advice. Risk managers are always important, HR as well, because sometimes these threats do involve employees. It's not just patient centered. And then we're also talking about our behavioral health professionals as well. If there are underlying psychiatric concerns, what can the behavioral health professional tell us about that underlying disorder or concern?
So, for the management part, do you guys make referrals to services as well? Like, if that seems like something that somebody needs?
Absolutely. So we work really closely with our community outreach teams. So we work with all of kind of the co-responder teams within the state of Colorado. And then we will also refer outside if we need to. Hey, we see that this patient might live out of state in Nebraska, for example, and we will find their local jurisdiction and whatever their crisis response team is, we will loop them in if there's some kind of escalating or community issue that we feel is appropriate for referral.
So it's really like an extensive approach, and kind of the old adage of it takes a village is really coming to mind here. And I fascinating to me, and absolutely I applaud you guys for having this extensive. I don't think I realized you had this extensive of a program there at UC Health.
We certainly made a very big village when we were creating these programs. We were very intentional about our approach to include community response.
That's
Yes.
Yeah, that's fabulous. No, the community response is so important. And I've been kind of trying to push that message out there of like, look, if we really want to decrease violence in healthcare, we have to look at the social issues that are going on. And it's really going to take a community approach to really help tamper this down. Do you guys participate in any kind of like community messaging or any messaging that the hospital puts out or that you're aware of? I'm just curious.
The university is part of several community anti-violence initiatives, safe handling of firearms initiatives. So the University of Colorado, the CU School of Medicine is very, very good about kind of promoting some of those through the violence reduction programs that they have.
Yeah, I think that's something that's been really incredible is that overall there's a focus on violence reduction, period, like from the community to the hospital, which is really what you need. Also want to give a big shout out about the work with the co-responders that Rachel and the team has done, because this is another way that we go from bedside up, right? Is that in the ED, we see these teams, they will come in with a patient, but then they leave. And we are kind of like, okay, great. I think they did a really nice job, but there's no like ongoing support. There have been times when I've reached out to Rachel to say, hey, I have a question about this patient. And she can communicate with co-responders and be like, co-responders are aware of this patient. You will likely start to see them come with this patient to the ED. And that starts that relationship at the bedside between our community partners. So they're really doing like our security partners are doing such a good job of laying the groundwork for us to have strong shoulder to shoulder relationships with our community partners as well. It's not, only happening in a boardroom. This is really going all the way down. It's very impactful.
No, I think you made a really good point, Renee, there on, a lot of times you don't know what's going on behind the scenes, right? In another department. And so having that collaboration and that communication is essential. And a lot of times it comes down to just asking. I think we can get caught up in like, well, I'm going to assume that that department's taking care of it, or I'm going to assume they don't, they're not following this patient because I haven't seen them. So I may make the assumption they're not being supportive. They're not, on top of it. And so sometimes it's just as small as just like, hey, reaching out and, making that communication and finding out and asking the question, right? So is that kind of more of you kind of take the lead on that? You said you were kind of that intermediate kind of person.
Absolutely. So I reach out and connect with all of our law enforcement partners in the state and for our affiliates out of state when it's appropriate as well. And we've really gotten to the point with our team's reputations that our partners know if we are reaching out for assistance in managing some kind of threat or escalating behavior, we've really tried internally to address a lot of the issues already so that we're reaching out not just because we don't have the resources or the ideas, but that this is at a level that really does warrant community involvement. We're not just calling police or calling co-responders because we don't want to deal with it. We've tried everything already in our playbook.
No, that's amazing. And then kind of same thing for you, Renee, right? Like you seem like you're kind of that intermediate between maybe like the bedside staff and security and yeah.
Yes, I definitely think that, as I said before, we have to be able to learn from what security is doing and what their practices are. And Rachel's laid such a strong groundwork with our community partners that it's been able to really positively influence the bedside when we have our law enforcement officers come in and we know them by name or we recognize them and we get those positive interactions create a safer environment for everybody because we get more context, we get a better understanding of what someone's gone through, and we just feel safer. While feeling unsafe doesn't always translate to actually being unsafe. feeling safe can certainly allow us to regulate our responses a little bit more and create an environment where safety can flourish.
Yeah, no, that's amazing. Do you guys do joint trainings between like nursing and security? Talk about that a little bit. Take turns. I want to hear.
We do. So our de-escalation training is offered for all clinical staff and security, and those certifications there's an initial and then an annual research, and they are interdisciplinary. Behavioral health professionals, nurses, and security all participate, and there is a drill component of that in that recertification and initial certification where they get to work together. There are also drills throughout the hospital in a number of ways that we collaborate, not just around violence reduction, but there's disaster trainings and things like that. But we also have our behavioral health response drills, and we always collaborate together. So our clinical staff and security are practicing together and practicing the same skills and are trained baseline with the same skills.
No, that's
That was a
great. What about?
really intentional change 2 years ago. So it was not always like that. You know, we had security de-escalation trainers and they were teaching the same material. But what we found was when it was time to go to the bedside and there was mass confusion about, well, this is what I was taught, what were you taught, who's taking the lead? And by just combining them all right off the bat, we've really eliminated a lot of that confusion among the staff.
No, I think that's great because when in nursing, when we train like our ACLS, right, Renee,
Mm-hmm.
and we train those codes, you have a team leader, everybody breaks out their roles. When you're doing it, you got your little note card when you're
Yes.
doing the training that tells you like what your symptoms are or what your role is. And so, I applaud you guys because I look at these kind of responses as in exactly the same way. Like you have to set up like who's going to be the kind of the
Mm-hmm.
leader, right? The leader of this scenario to kind of help direct everybody. And you really need that when you're responding to these types of incidents, especially if it's somebody that is like highly violent, you're trying to put restraints on. I think if you don't have somebody coordinating that, it's going to be a lot more stressful for everybody involved. So it sounds like one of the ways that we can kind of combat burnout and that fear and that stress of these incidences is having kind of that coordinated trained response, right?
We have a gentleman who has a behavioral health background. He works at the system level, and he really has partnered heavily between coordinating his instructors to really make sure that it is a very collaborative approach to training and response. I think that it also lends to an environment where we're seen as one team. We are not, us versus them. It's not, clinical staff versus security. It's all of us. We're all here shoulder to shoulder. We need to feel safe. Similar to our Code Blue drills. So those I really have tried to find, and I can't. So if anyone out there is listening and has the answer to this or can speak to it, I'd love, please reach out somehow and tell us. But before we had ACLS, before we had an algorithm, I think that when people lost pulses, it was chaos. And I don't think people knew what to do. Or they tried, we know that there were really poor attempts at to get pulses back. But I think that when we realized that we could and we were trying to accomplish that all the time, I think it was chaos. There was lack of trust among the people in the room. There was a feeling of fear. There was, our emotional brain responded to that instead of our algorithmic brain. And what's interesting is that we see that in some of these responses. And the more that you can structure them and the more that you can build trust among the team responding, even if you don't know them, if you know that they have the same training that you have, you can run it, you can handle it. And I think we're just at that, we're still at that beginning stage as a culture, as a world, global response to these. And it'll be very exciting to see how this develops over the next, decade. When we look back and are like, remember when we didn't have an algorithm for this?
No, I totally appreciate that our clinical brain works kind of in those algorithms. I'm gonna flip it for a
Yes.
second though, because I have attended some behavioral threat assessment trainings. In fact, I did the what was it, Rachel, the FTAM training that ATAP did not too long ago, and they had mentioned that it's very hard to use
Hmm.
algorithms in behavioral threat assessment training. So, Rachel, to kind of flip it to you, can you dive into that a little bit deeper and maybe how can we work through this?
Absolutely. So, I think the tendency to use algorithms is to identify a behavior and then a set response. What we're doing with behavioral threat assessment is just a structural review. First of all, get everything out on the table. Like let's throw every factor out there that we've got. What are we seeing to identify one issue, right? What is the one underlying grievance? I think is the ultimate goal of behavioral threat assessment, to redirect that person off the pathway to violence. So you can't necessarily say, okay, for this behavior, we're going to redirect this way, because you don't know what's triggering this behavior. So really, you're going one step back. So before you identify responses, you have to identify root cause. And that's really the difference, I think. When you're talking about a clinical algorithm at the bedside, hey, this medication is great for this. Wonderful. What are we doing long term? Because when we're talking about behavioral health threat assessment, we are talking about somebody who's spending 2 weeks or more fixated on committing an act of violence. And that's a little bit different, because we want to identify, okay, what was that thing that triggered that fixation to begin with? And then we can look at, okay, now we can start to talk about what are some of the different things that are going to redirect this person. So we might not be looking at an algorithm, but we are certainly looking at a systemic process to review those things on the front end.
So what do you think we can do in the immediate moment though? Because I think that's where like Renee and I and like our, our nursing brains, right? So like in ACLS, you have your H's and your T's, like what's causing this code, right? Your H is your tamponade and
Hmm.
hypothermia and all of that. So go ahead, Rachel.
If I can figure this out, I'm going to be on an island somewhere, guys. I think one of the things that I tell our staff, right, is hey, let's acknowledge the feeling of fear, because that's thousands of years of evolution trying to keep us stay safe. So it's okay to say, you know what, I am afraid. I am afraid of what this person has just said to me. Now I need somebody else to come in and be that neutral party to evaluate that. It's okay to remove myself from that situation. We spent a lot of time giving our staff permission to leave the room if they
Hmm.
feel unsafe, so that we can then on the backside objectively assess what the issue is. That's the first step right there. You got to take the fear out of it. And it's okay to be afraid. Let's
Hmm.
let somebody else, once you're afraid, conduct that analysis. The second thing that we do is, and of the spoken or written word is so important in this process, because what we hear, our minds are great at playing tricks on us, right? We might hear this person say, you know, this makes me want to go get a gun and shoot somebody. That's very, very different than, you know what? This doctor's really pissing me off. I'm going to go get a gun and solve my problem. Those are two very different threats. The problem is they're registered the same way a lot of the time in our minds. So we really need to understand, because if we do have somebody who's saying they are going to go get a weapon and it's targeted at this specific provider, that's a very different response to somebody saying, you know what, this makes me want to shoot people. And we've got a whole generation who their response to things that frustrate them is, man, this really makes me want to shoot something or someone, right? So those people need to be redirected that this behavior is not appropriate, but that's not threatening behavior towards somebody specific. So step two is really looking at the written word. Step three is, okay, from that, what is our grievance and what can we do to address the grievance? Sometimes it is as simple as an outbound phone call to the patient to say, tell me what's going on, right? And it's something really silly like, hey, my dog just died this morning. I got this bill in the mail. I had to wait on the phone for 45 minutes to speak to somebody. And when I did, they asked me a bunch of stupid questions that we all know are for their identity verification, right? We all know that there's a good reason for them. But for somebody who's having a bad day on top of a bad day, that's not what they want to hear. And we can just simply redirect them by opening our heart before we decide that opening the police department is the way to go.
No, I
Yeah.
like Yeah, no, I think that's great. And yes, if we can come up with an algorithm, definitely.
Can't. Because if you
Get
think
there.
about I think for the in the moment, right? You have
Yes,
someone who we're at the bedside, they suddenly escalate. What are your three things that you're going to do and evaluate for every time, and who do you call? And even just that, like knowing, I know that if I am feeling feeling for a pulse and I don't have one, I know what my next step is. I am going to go
right.
for help and jump on the chest and do compressions, right?
Yeah,
Now, if you were to pick up a lay person and say, okay, you don't feel a pulse, they're going to be like, oh my gosh, they're dead. I'm going to call 911. And like, great. And then in 5 minutes when they get here, hopefully someone jumps on the chest. What is the website of the circulation? So like, I think getting some kind of for those in the moment algorithms so that we can get to the H's and T's. What caused it? That is going to change. Are we just like in a code? Do we need to? Is this a blood glucose level issue? Is this a cardiac issue? Is this a traumatic issue? That changes then what we do, but we have first stabilized it. So how do we stabilize? And then get into that piece of what is the root cause and who do we reach out to? Is it Rachel's team? Is this actually something that isn't a threat, but we're still doing something? There's something about our environment that is causing a reaction in this patient. And how do we identify that and then alter it so that we can provide safe patient care and
yeah.
keep ourselves safe?
It, yeah, and and just in talking, and this is why I love talking, it's almost like it's not so much like the same type of algorithms that we would use, for a code, but more of kind of doing those bullet points of what your policies are. So taking your policies and kind of just putting it in like a nice bullet point, like kind of algorithm, like one sheeter, right? Just a
Mm-hmm.
one sheeter that you can have laminated, that you can have, disseminate and pass out to staff, that when you're in these situations, per policy, like this is who you're going to call for this, or this is who you're going to do. Because I love our policies, but sometimes like sitting there and trying to like read through it in the moment, especially, right?
In the
Like in the
moment,
moment,
yes,
it's what am I supposed to do, like in the
right,
moment. I think another reason nobody's really done it yet is because it's going to vary by organization, right? Like what
totally.
resources do you have available, and vary by organization. But I think that's probably a pretty good reframe for it, is it's more of an algorithm for your policies, right?
Mm-hmm.
And I think
And
we have
just
some of that, and we've just
Mm-hmm.
not done a very good job at overlapping it, right? The immediate thing that comes to mind when Renee was giving her example is okay, our early medication for agitation algorithm.
Yes.
If we can identify where we're headed early on and we can remember and teach our staff to, hey, this is the agitation pathway, right?
Mm-hmm.
When somebody's first starting to show those signs, even in our security training, what do we talk about? The hands are the weapons, or the hands control the weapons. So how do we overlap and lace all of those things together? But I think more broadly is, how do we empower staff to then say, this is what's going on, provider X, please help us with this. This is what our pathway recommends right now.
yeah,
Totally.
so it's creating, I think, just like a visual for the policy, right? So you're taking the policy but making it just more visual to be able to look at it. And then it sounds like you guys have some other algorithms in place, so you almost have an algorithm to refer to another algorithm.
Oh, yes.
And they're all interactive. And I
And
love
they're
that.
all
They're
interactive.
all interactive.
So,
So it sounds like we need an app more than we need.
yes. And
Oh,
I think
go ahead.
I want to touch on something Rachel said, because I don't know what your perspective is. I've heard her mention, we watch hands. And I was like, okay, cool. Sounds really boring. I'm way more interested in the wound on the leg, but okay. And then through our time working together, she explained it was a meeting. Like, I realized I should have asked this months ago. Why are you watching hands? And they just accepted it as the thing. And she was like, because they're the weapons. Like, you can have a knife on a person, but if the hands aren't on the knife isn't going to do anything. You cannot have a knife and you have hands, you have weapons. Hands, legs, right? Like these things that when you are not viewing the world through a lens of needing to keep yourself safe. If someone has chest pain, I walk into a room, I immediately look for the color of their face, how they're breathing, and then at the monitor for what rhythm I'm seeing, right? That is where I go every time. And so being able to take that piece of security and law enforcement practice of hands and go, hold on, we have to teach the clinical staff this. They aren't thinking that. That is that bridge that where we come together and work and can really implement safety measures.
Yeah, and I would even caveat that in that if somebody is in the bed, yes, hands.
Yeah.
But if somebody is standing, and I knew this from my training, but I took a training recently with Michael Rosen. He has a threat assessment company. Sorry. So I did his training, and he had mentioned his that he feels the feet are the most honest part of the body, because actually the feet will move first. You'll see somebody blade or kind of shift their weight before they even do anything with their hands. And I know, like in my self-defense training, that's one of the things we try to actually untrain, because it is like a tell. So we try to actually move hands first before we move feet. That way we're a little more kind of ninja. So just to kind of throw that in, just for anybody listening, you can also really like look at the feet, because sometimes the feet will move first before the hands even will. But I think for us, for clinical, most of the time everybody's in bed. They're not necessarily up and standing. So no, that's awesome. I know.
On pre-assault indicators because
Yes.
it's an all of the above. Also, sometimes people will just tell us what their intention is. Stay away from me, or I'm going to hit you. Let's
Yes.
believe them until we know
Yes.
otherwise. Absolutely.
Yes.
Yes, leave the room. If
Yes.
someone yells at you, get out. Okay.
Yeah. And that needs to be in the algorithm. I love that you guys have given permission to leave the room,
Mm-hmm.
and that's in the algorithm. We're going to add that. You have permission to leave the room and get
Mm-hmm.
help.
Yeah.
So I know we're a little, Rachel, you got a meeting after this and we're a little short on time. So I want to kind of wrap this. What are some changes that you guys, or new technologies or whatnot, that you're excited for kind of in the future regarding healthcare safety and security?
At the risk of sounding very old fashioned, I am really all about getting back to basics, right? There are a lot of cool technologies out there that promise a lot of things, but what I continuously see missing in the healthcare security environment is a foundational understanding of basic human behavior and how we respond to that, right? We don't understand our own responses to violent behavior. We don't understand somebody else's behaviors where they're getting ready to assault us. And we can have all the cool technology in the world, but we don't record in patient rooms a lot of the time. You know, we don't have the AI overlay to tell us that somebody's preparing to be violent. We just have to have that good old fashioned baseline understanding of human behavior.
Yeah, no, I really like that, Rachel. Thank you. Renee, what about you?
Yeah, I am going to sound just as antiquated. I think that there's their technology is only as good as the foundation that it's placed upon. And I think that awareness around workplace violence has continued to increase. I think that we will see our foundation get stronger. And that is what I'm most excited about. And the relationship building, the community partnership building, the changes, and hopefully access, more access for people to be able to get the resources that they need and the help that they need in the community. I think that's what I'm most hopeful and excited about.
Yeah, it's so multi-tiered. I mean, it's bigger than just the hospital, right? It's bigger than just our
Mm-hmm.
healthcare system. It's our government. What policies are we implementing and that are affecting healthcare and all of that? It's really having an understanding. There's your micro understanding, but then there's really like a macro understanding. And Rachel and Renee was saying security, connecting all those dots, right? You got to pull in all those dots, connect all those dots to get the bigger picture. And so, it's not just what can the hospital do to keep me safe. It's really what do we just have to do as humans, and as a community, and supporting each other and helping everybody reach their optimal health. Because I know for me, like a lot of the violence that I actually aggression is just people frustrated that they can't get the health care that they want.
Mhm.
Yes, we have the drugs and alcohol and dementia
Mhm.
and that, but to me, that is much more rare than the person that I have coming in every day who's just upset that they can't get the health care that they want.
100%.
Absolutely.
Yeah. All right. Well, how can people get a hold of you guys if they want to reach out to you? What's the best way to do that?
LinkedIn is absolutely the fastest way to find me. Connect with me there. Happy to have a conversation, brainstorm ideas and talk about things that have worked for us at our organization over the past few years.
Yes. LinkedIn, same for me. If somebody out there has a really awesome story that they can share about life pre-algorithm for codes, I would love to hear it. I'm living for it.
All right, ladies. Well, thank you so much for your time today. And you guys have a wonderful rest of your week.
Thank
Awesome.
you.
Thank you so much.